high atop Rodney Square in beautiful downtown Wilmington, Delaware.
We are the Podcast Pediatricians. I'm Rob Walter.
And I'm Matt Gotthold. Check us out on iTunes, Spotify, Google Play, Podbay, and podcastpediatricians.com, where you can leave your email and receive alerts for our episodes.
Does anybody use Podbay or Google? We say that?
Yeah.
I don't know.
I don't know.
I don't know either.
You write this stuff.
And so, as you know, we've been coming to you from Caesar Rodney Square for about 6 years now. And by the way, happy 6th podcast anniversary, Maddie.
And to you, my friend.
Almost 82,000 downloads. But starting today, we went to the correct name for our broadcast site, which is just the Rodney Square. Those Delawareans in the know have heard that Rodney Square, the central public square in Wilmington, is being totally redone, I think about $8 million worth, and beautified.
Wow.
But it now will forever be without the statue of Caesar Rodney, who was a Revolutionary War hero, but also an enslaver. So I guess we have to figure out who's going to take that little spot, that statue. Any ideas?
Well, there are only so many famous Delawareans,
right.
I think.
So I know, you could go with the president.
But
I think it's got to be the Aubrey Plaza.
that would suit. Yeah, for sure. Who doesn't like her? Right?
Exactly.
Perfectly appropriate. Makes perfect sense.
Exactly. So, Matthew, Boker Tov, I'm back from the Holy Land, and ask me how I'm doing, Matt.
Roberto, I don't know how to say that in Yiddish. Roberto, how are you doing?
Beseder.
What?
Beseder. It means like okay.
Oh, okay.
I just like a little Hebrew out there.
Nice.
So I took the Jesus and Jewish tour in Israel. So it was really amazing. The Western Wall, the Dead Sea, the remote crater, Tel Aviv. We went to Tel Aviv for Purim, and the bar we were partying at 2 days later, there was a terrorist attack out there. So that happened.
Dodged some trouble there.
But also, there was a lot of women clad in red protesting all over the country because they're trying to gut the Israeli Supreme Court, which would really gut women's rights if the more hard-right Orthodox Jewish community made the rules. That would be catastrophic. But also, I thought of you, Matt. I went to the Church of the Holy Sepulchre, the Mount of, is it Beatitudes?
Beatitudes, yes.
Beatitudes.
Blessed are you who?
Tiberias, the Sea of Galilee. Now, did you know, Matt? Because I didn't. There's a story about like loaves and fishes they were telling me about.
Oh, please. You don't know the story of the,
I do
the
not
loaves
know
and fishes?
the story
Goodness
of
gracious,
You've heard of it
man.
before?
This is one of
they
Jesus'
make that up?
Many miracles.
I did not know that before. And we were on the Sea of Galilee, and with a boat of Romanians. We snuck on the last people on a boat on a pilgrimage with their patriarch saints and colorful vestments. And we started singing Romanian songs and drinking some kind of Romanian drink.
I didn't know you spoke Romanian.
I do not, but it was really fun.
How do you know what you're singing then?
I don't care.
You may have just joined some satanic cult. They'll be coming by for your firstborn any minute now.
Okay.
Okay. All right. So since you were there, you should know this. After whom was the city of Tiberias named?
Tiberius.
Duh.
The famous Roman general. I don't know. Is that who it is?
So when I was looking into this, I think he was the second Roman emperor as a Roman history minor, most of which I've forgotten by now. But there are 4 holy cities of Judaism. What are they, Rob?
Well, Jerusalem.
Don't look at the script. I put this in.
All right. Jerusalem is one.
Yep.
And not Tel Aviv, because that's a modern city. That's new. Hebron. And
well, you just mentioned one of them.
well, I said Jerusalem
No.
and Hebron. Oh,
No.
Tiberias is
Yes,
another? I didn't know
indeed.
that. I don't know. What's the fourth one?
And Safed, which I had never
I
heard
went
of.
there. That's
What-
a city of artisans.
There
Like
you
we
go.
bought,
Yeah.
I bought mezuzahs there and all kinds of glassware.
Yeah, thanks for the mezuzah.
Yeah,
Not.
sorry.
Yeah. Yeah, these were the 4 main centers of Jewish life after the Ottoman conquest of Palestine, from what I could read.
Well, thank you, Maddie.
Yeah, man.
I'm glad to hear that. So, okay, we're going to go on a little bit different after 6 years because I have a lot of free time. So we're going to do some random topics and throw them out there, okay? First of all, Matt, and you'll love this, I started taking guitar lessons. and oh my God, I'm horrible. The clue was that I can't type. I do the dragon voice because I can't type.
You can't do that into the guitar.
Right, you can't do the guitar. Plus, I realized like a third lesson, like the reason I do dragon is because my fine motor skills totally suck. So I haven't seen you play guitar.
I did see your case downstairs. I'm gonna have to fiddle with that. Next time I come over.
My nurse's husband was a professional guitar player in the Wall of Sound in Philly.
Nice.
Mike Ziegler. He gave me a guitar that was built in 1961 when I was.
Sweet.
And I took lessons. The best thing I got the first day, the guy was like,
Yeah.
"That's a nice guitar." He looked at me like, "Wow," and then like. The rest of the whole time, he looked at me in disgust because I was.
And the second time you went, he said, "That's a nice guitar."
But the one thing I got out of it, and we went to this Ripe concert, is that now when I watch people play guitar, I kind of really appreciate it, and especially,
my goodness.
I always thought like it's the left hand and all the different chords. That's the hard part, but the strumming is hard, right? The different types of strumming. So
I just went to see a show.
Tay-Tay, you saw. I heard that.
No,
you
I
went
didn't
to see
see
Taylor
Tay-Tay,
Swift,
dude. I wouldn't want to take your ticket.
I know you're a Phoebe Bridgers fan. But
I am a Phoebe Bridgers fan.
Okay, well she was there too.
Actually,
but you didn't go see Tay-Tay?
I did not. Although I went to see John Butler without his trio, but he had this.
Does
the
he
man
play with
played
Taylor?
for like 2
Does he
hours.
play with Tay-Tay?
Please.
Okay.
He's like the anti-Tay-Tay.
Okay.
But no, he put on a one-man show at the Fillmore in Philly. It was awesome. And used his looper to incorporate like his own voice over and over again and his rhythms, and he would play one guitar part and record it and then go on. Have you ever seen anything on YouTube by Nandi Bushnell?
No, I have not.
Oh, dude,
I have binoculars that are called Bushnell.
No,
is
so
that
this
same?
is a little girl who actually
Okay.
befriended Dave Grohl, the lead guitarist and the head of the Foo Fighters, who I don't know very well.
Terrible
My brother
name.
does.
Terrible
Yes,
name for a
exactly.
band.
But he
Okay.
used to be the drummer for Nirvana.
Oh, okay.
Dave Grohl, and so she actually called him out on social media that she would challenge him to a drumming contest, and he's a consummate drummer. And but if you go onto YouTube, this is a little girl who, I forget where she's from, but she's probably at the time she recorded these things like 10, and she is a multi-instrumentalist and does her own vocals.
Wow.
And essentially uses a looper. And so
Wow.
the first thing that I watched of her was the Rolling Stones' "Give Me Shelter." She did all the parts herself.
Wow.
It's just mind-boggling. I have to
Wow.
check it out.
That's the beauty of the internet, right? Like people like that can.
Absolutely. And the power of a looper, which I'm not sure if you're familiar with them, but essentially you record a short segment of music, and then when you're ready, you hit the button, and it just repeats itself over and over again.
Okay, I
So you
thought,
can have
I thought
multiple
the looper was some
voices.
guy who like helps you play out. So
That was a
thank
movie,
You for
yeah.
making all that. So, and this,
Well, I think it's called a looper.
And this is, to me, this is kind of the summer of the concert and stuff. Like, so I know you went to Tay-Tay.
Yes.
So
No,
we're
I
both
didn't.
going to see Bruce.
Yes, we are.
I'm going to see James Taylor.
I've
and
seen him a zillion times.
I know.
Yep.
My favorite song of all time is probably Sweet Baby Jane's.
Okay.
And I'm so excited. And then Ed Sheeran I'm going to see.
Speaking of loop,
In Philly.
he notoriously used a looper.
Yes, he got it, and he just got acquitted. He
Yes,
was
he did.
sued
For
for
swiping music.
copying, and he didn't. And I thought it was great. But seeing him, and then maybe Miranda Lambert. I know you're a huge country fan. So anybody else you're going to see?
Actually, Diana and the girls are going to see Leanne Rimes at the Grand
Nice.
tomorrow night.
Nice.
I'm an alt country fan, not a country fan. In fact, I was going to propose that you go to see the Turnpike Troubadours with me in July at the Beacon Theater in New York City.
Ooh, okay.
Tuesday night.
We'll talk
Mark
off-
your calendar.
Offline,
as they say.
Yes. All right. So, and quickly, I put it in here because our last book club, we did a book called Stephen Florida about college wrestling. Oh my gosh.
Talk about it, an intense dude in his head, right?
Wow.
What a study in like a personality, right?
It's called Stephen Florida. I'm not sure I'd say that people will love it, but you won't forget it.
No, if you want to appreciate somebody who's driven and who is has a singular goal, that's what it was about.
Although we did talk about that, wrestling, the eating disorder issues, and the disgusting skin diseases. I mean, wrestling's a wonderful sport, but it's problematic, especially boys. I've got a couple boys who've gotten eating disorders, starting out with cutting weight from wrestling. So here's another big one for both of us. the mask rules. So what
Yeah.
are you doing with masks now in your office?
Well, you know, we waited until your practice liberated things.
You texted me like, are you going to stop using masks? We're like, I don't know.
We don't want to be the only guy in that boat, right? So actually, it was nice because I think the local children's hospital and the local adult hospital and the rest of us kind of decided at the same time that it was time to put that one in the drawer for now, right? So, but it's been it's been a great experience. My staff feels very liberated. It is kind of it's questionable the efficacy of it at this point, especially with the number of people in the community who have already had some experience with it. Number one, although that's not an exception, but also it just really has dissipated in this community.
It really has, and we've had some, but and now I'm carrying my mask on with my computer. So if I walk in the room and everyone's masked, and they're looking at me like, okay, I'll put my mask on. I want them to feel comfortable. Yeah. And I don't know about you. We talked about this before, but I think for the rest of my career, if I have a kid who has a fever and especially coughing, I'm going to put a mask on, even with strep, because we used to get sick a lot more, right? As pediatricians.
Well, you guys in your 70s should probably take care of yourselves.
Wow. But still, so what about you? So are you going to wear a mask if someone's coughing and febrile?
You know, I'm so scatterbrained that I'm not sure I would have that insight, although I will have them available in the office to do that. Yep.
Right. So it is nice walking around. Like you feel like what's wrong? I don't have my mask on. Yes. And then you see people that you've only seen in masks before, and you're like, oh, that's what you look like. I'm sure they're saying
really, because I'm more like this.
I'm sure the same thing about us.
Miss McGillicuddy, you are not what I imagined you to be.
All right, here's the other big one. So when parents are saying, so what are you recommending for your COVID vaccines for kids now? What are you saying? I'll tell you what I'm saying.
I'll tell you, maybe I'm just going to shoot myself in the foot here, but I'm telling you it's a reasonable thing to do is what I tell them. And then I also say that the majority of the effectiveness with this vaccine, to my understanding of it, is with the initial doses and not so much along the lines of the boosters, because their degree of effectiveness seems to be for a limited time. So, I mean, that's where and I don't want to at all sound like an anti-vaxxer, because that's completely what I am not. But I also recognize the fact that this is a vaccine that people already feel ambivalent about. And if they can get at least the initial, couple vaccines in without necessarily the booster at this time, right? Because it's constantly being iterated, apparently, then that would be preferable.
Right. So we're doing the same thing. I'm like, it's complicated. And we've talked about the kids have an innate immunity, and so they don't get it as much. And we're down here. We do have it in the office. The new guidelines came out that they're no longer we're giving the monovalent ever anymore. So it's only the bivalent, the new one. And it basically says for most of the ages, if you've ever had one vaccine before, anything, monovalent, whatever you did, just one, then they're just recommending one more, at least 2 months after the last one. And if you've had multiple ones before, but it's been a long time, then one more maybe once a year. So I'm kind of saying like maybe you'll get it when you get your flu shot in the fall. But I say, well, if your grandmother moves in who's got chronic lung disease on oxygen, that may change what you do. Or if a new strain pops up that's hitting kids, which is extremely unlikely, that would change how we look at it. So I certainly will say, as you do, though, I do generally recommend it. It's not a huge uptake now, but we're going to have it. And we'll see if any facts change on the ground. But we're probably a little bit pushing it less, you started to say, than the AP would want us to do.
Oh, indeed. I think we are, but that's why we have this podcast.
Right. And speaking of the AP, they're kind of on my bad list, because I submitted a proposal to give a talk at the fall meeting in D.C. called The 7 Questions You Must Ask at a Routine Well Visit. And I think you heard...
I've heard iterations of this
or 7
before.
questions you must ask at a routine teenager well visit.
Yes.
I waited and waited to hear. I'm thinking, like, well, I'll have to get a hotel out there, because, of course, they'll take me.
You mean they didn't say, the Rob Walton?
Yeah, I know. So then they said, it's coming, it's coming. And then I finally got an email decision. And all it said was my name, the name of my talk, and then it said status, reject.
Dude, I've been trying to tell you that for years.
It could have said we pass on this, or not accepted at this time, or denied, but no, just reject.
Nice.
So thank you, American Academy of Pediatrics, for telling me where to put it.
As such a non-confrontational and sometimes equivocal organization, I think they're pretty firm on that.
Reject. So here's another thing I put out. I'm going to talk at the Disney meeting, but I don't think anyone's been talking enough about one of the biggest changes in medicine the past few years is the proprietary program Up to Date that everybody uses. I talk to my OB friends, they use it all the time. Surgeons, internal medicine, family practice. It's really, and I use it all the time.
Yeah.
And I look things up. I say, wait a minute. I go look things up. It's changed dynamic too. Like we'll have like our new nurse practitioner who will present something to you and a thing, and they'll say, "What are you thinking?" And then they'll spout out like a treatment plan. Like, how did you know that?
Right.
Well, I just looked up on Up to Date. Now, I think it's going to keep up to date, and obviously, we have to make sure we use our clinical acumen. It's not like anybody can read it and say this is what you do. But I don't really look at textbooks much anymore.
No.
And they have handouts for things. It was actually started, a friend of mine in Boston. It was one of his classmates in medical school, I think, who started this. He must be rolling in it.
It's brilliant.
But it is great. I mean, I haven't heard anybody say anything
pricey,
bad about it.
But
it's
for
pricey.
somebody who accesses it on almost a daily basis, like I do, like certainly it's worth its weight in gold.
So
because
again,
it is again up to date. This is what people who are smart about this topic think about this topic within the last couple months.
Right. And so anyway, so I just haven't heard any articles looking at how much we're using it. I'm sure they'll come out.
Oh gosh, yeah.
And I'm sure when I have no connection with the company, but it is something that's just kind of changed a lot of how we practice for the better.
Yeah,
and really,
and they are pretty good with peds, right?
Yeah,
because so many of those types of resources seem to have much more of an adult bent. But the topics on pediatrics are written by pediatricians.
Right. You look at who's doing it. These are the people that we think are the gurus.
Folks. Exactly.
So they really do.
It's been a
they're not asking us to write anything.
And plus, I mean, they're right on. It's on our phone, right?
Right.
We carry this like mega computer in our pocket,
right?
And before, if I'm ever, as you well know, in pediatrics, we see a lot of the same things over and over again. But there are some things that we only see once a year or once every couple of years, and if we want to make sure that what our knowledge base is pertinent to the current day thinking, then we just flip that baby up and we're off to the races.
Another thing I randomly wrote down thinking about is that we both do newborns, and when we go into the child's chart that talks about the mother's history, it seems like every mom has a history of anxiety and mood issues.
Yes,
and I mean, it just reflects what we're seeing, right?
Yes.
And then how fraught it is when you're bringing a new baby in the world. But that used to be the exception. Now it's like the rule that moms have anxiety or mood issues or both.
It is. Yeah, it's really and again, it's like some of the other things, like the recognition of autism, et cetera. How much of this is a consequence of the world we live in? How much of it was previously unrecognized?
Right. We're screening for it now.
Right.
That's absolutely true. I also wanted to say just briefly, it's in the news a lot about gender affirming care and transgender care, and it's political football, and I think a lot of it has been horrible. But I always talk about the New York Times, and I like that group, but they put out an article last year basically saying that some of these puberty blocking hormones really affect the bone density and that it's a big problem. They should stop it. And when other people delved in, it really was not a good article. You could say there's some questions about it, but they did not ask any of the people who actually use these medications and such. So, and basically, if you use puberty blocking hormones and you give enough calcium, vitamin D, there shouldn't be an issue there. The World Health Organization yesterday came out against use of artificial sweeteners because they don't reduce weight and they increase the risk of type 2 diabetes. I'm sure there was a lot of lobbying against it. We've said this before, that when you use artificial sweeteners, your tongue feels the sweet, but then your microbiome doesn't get the sugar, and it makes you eat more. And it's a huge deal because these artificial sweeteners have put their way into so many food stuff. Like if you go to the store, it always says, here's a reduced calorie version, and they're all using these sweeteners. And this just crystallized to me that we got to tell people, don't use artificial sweeteners.
Right.
Now I know Matt grew up on Tab.
Fresca,
he just
dude.
Drank
Fresca.
Tab all the time.
Fresca.
So it's tough. But I don't know if you've been telling people about stay away from artificial sweeteners.
I'm never a fan of something that tries to fool your body into something else, aside from maybe vaccines, right? I mean, to try to get the same type of an effect from something that's artificial, it's got to be suspect on some level, right?
Right. So a quick shameless plug for Hot Topics in Pediatrics, July 20th to 22nd, again at the beautiful Grand Floridian Hotel. It's going to be hot controversies, one on should we genetically screen all newborns with their exome sequencing, and I think that'll be really interesting, and another on should young athletes specialize. That'll be with our friend Brad Bly.
Awesome speaker.
Sports medicine guru. Will be done around 1 o'clock, so people can get to the parks. I know Matt's not going this year because if he was, he'd go on the Guardians of the Galaxy ride at Epcot, the new Tron cycle in the Magic Kingdom.
They would have to pry me off of those things.
Anyway, so if you're interested, just Google Hot Topics in Pediatrics at Disney World. It'll be fun.
Indeed. So the meeting kickoff lecture is on infectious disease, with one of the lecturers being Delaware's own, Dr. Craig Shapiro, on the topic of bugs and drugs. Now, this is always a popular type of lecture because we get to find out, is there anything new in the world of infectious disease? He came into Rob's office, I think, and gave a preview of the talk. And from what Rob tells me, one of the big takeaways was that cephalexin, it's old school first-generation cephalosporin, is king.
Also known as Keflex,
yes.
It's the king.
Mm-hmm. Okay, of course, high-dose amoxicillin is still the drug of choice for otitis media and for pneumonia. But remember, once-a-day amoxicillin instead of twice-a-day amoxicillin for strep is now perfectly acceptable, 50 milligrams per kilo with a max of 1,000 milligrams per day, which Rob apparently has started doing. I'm still a little bit leery about how that's going to, bug up somebody's gut from the standpoint of causing GI issues. So I kind of have been sticking still to the twice a day.
Don't you think it's worse giving 875 twice a day than giving 1,000 once a day?
I'll vet my experience through your patient's gut issues,
I
not
think
mine.
that your patients will have more gut.
We shall see.
And also resistance, right? Less antibiotics, you get less resistance.
This is
Don't
true.
you care about antibiotic resistance?
I do, but I also care about adequate treatment from the standpoint
I care
of them
about
taking their meds.
Okay.
You miss one dose. This is an old argument, right?
You're behind the curve. You're well behind
maybe
the curve.
I am.
Okay.
I'm a traditionalist. But for most soft tissue infections and urinary tract infections, the first line recommendation is usually cephalexin, aka Keflex. For many reasons, ceftonir, generic Omnicef, is now considered to be kind of a sucky choice. For most of the things the providers have continued to use it for. I had a kid the other day, a 10-week-old with a perianal abscess, and they put the baby on Clinda, and then they did an incision and drainage, got the germ, ended up being Klebsiella pneumoniae, for which Clinda wouldn't do anything. Ooh. Put the baby then on Bactrim, so trimethoprim sulfamethoxazole, and baby broke out in a rash the next day. And so I did a little research, and what was the drug of choice, Rob?
You going to tell me it's ceftonir?
No. Cephalexin. Keflex. Old school, baby.
Old school.
Yeah.
Old school.
Rob, do you guys use any IM ceftriaxone in your practice?
So, we have been using it a little bit more. And a shout out to my nurse practitioner, Tina, who got this organized for our practice. It's not easy to give IM ceftriaxone in the office. You have to reconstitute it with normal saline or even better with 1% lidocaine, so there's less pain. And sometimes a lot needs to be injected into those little thighs. So before I didn't have a lot of experience with this, but it's a great option for those rare treatment-resistant cases of otitis media. And we've talked about, we're just seeing a ton of ear infections, especially if they have multiple allergies to other medications like amoxicillin and such. So we administer the first dose in the office and then see the child back the next day and then give a second dose. The guidelines are they can come back one more time if they're symptomatic and assess whether they need a third dose. So we are stocking it now. It's cheap, and it also comes into play, obviously, with some STDs.
Right.
And I know, Matt, your practice has a lot more sexually transmitted diseases, so I just think that you guys definitely
You're saying my practice on the wrong side of the tracks? I don't think so. So, we've had the IM ceftriaxone in the office for probably 5 or 10 years now. But you're right. You don't use it so often that it's just naturally in your noggin. So one of my nurses was kind enough to actually draw, put instructions kind of and attach it to the box of the stuff so that when we do use it, which is, by the way, the last time I used it, which is typical, last appointment on a Friday afternoon, right? So in the chaos, nothing gets confused. We hate getting to the point where we have to consider IM antibiotics for otitis media, but sometimes If a series of oral antibiotics have been tried and failed, and the child's still quite sick and uncomfortable, or the child has allergies, like Rob mentioned, I think the most chilling thing that Dr. Shapiro shared with Rob's group was that it's estimated that by the year 2050, antibiotic-resistant infections will likely be the #1 cause of death. That's some scary business right there, brother.
Right.
Yeah.
That's why I'm giving amoxicillin once a day for strep, Matt. So we don't have that happen.
Dingus. Okay. Enough doom and gloom on that topic. Let's get right to it. As promised, there will be blood. Starring Daniel Day-Lewis as Daniel Plainview. But first, our disclaimer. We are sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community standards of care. Okay, there will and there must be blood. That was a great movie, by the way. I don't think everybody appreciated it. It was so understated but dramatic, and the cinematography was amazing.
It was.
Really good show. Okay, we wanted to review a few highlights and pearls from a very nice talk by Dr. Karina Schultz, an excellent hematologist on our own backyard at Nemours. As always, anything we say that's not correct is entirely our fault and never the fault of the speakers. And as usual, we will go off on tangents. The first pearl, which is something we don't think about enough, is a warning for us as primary caregivers to always be on the lookout for possible bleeding disorders in our pediatric patients. A few episodes ago, we talked about the phenomenon of some parents refusing the newborn vitamin K shot for their babies and opting out of that shot, and how that can potentially lead to horrific results, including an 81 times higher rate of late-onset vitamin K deficient bleeding, half of which occurs in the brain. But outside of that topic, there are certain presentations of other bleeding disorders that we as pediatric providers should keep in mind and consider potential bleeding disorders.
And the most common of these situations is that of frequent, heavy, and difficult to control nosebleeds, known as epistaxis. So routinely, these nosebleeds originate in the front part of the nasal cavity. If the origin of the bleeding is further back, then we have to consider more ominous things like a juvenile angiofibroma, which you mostly see in teenage boys. So the biggest issue is always, always, always look up the nose. And that always makes me think of Cheech and Chong about this little boy, Jaime, who kept putting things up his nose.
I remember
trains
that
and
skit.
boats and planes up his nose. And last week, whole bagel with
you have
lots
to be
of cream
older
cheese.
than 55 to remember that one. Yeah.
No one knows Cheech and Chong. It's sad.
Yep.
So I remember in my brief and somewhat unhappy turn as a radiology resident, we embolized one of these angiofibromas in a teenage boy prior to his more definitive surgery. And I had never heard of this type of tumor before my pediatric training. So these angiofibromas are rare, but always worthwhile looking up the nose to see if it's anterior or posterior bleeding, and you do not need a fancy nasoscope.
No, you do not. There are a few things more disturbing for a parent or a child than a nosebleed. It's often a matter of a parent finding a young child in bed with blood smeared all over the sheets, kind of reminiscent of the whole horsehead scene in the first Godfather. You remember that?
Yeah? I do.
Golly, yeah. Ugly business, yeah. For most recurrent nosebleeds, especially if they're heavy, we know that they usually originate in an area known as Kesselbach's plexus, which is a collection of blood vessels that's just below where the bone of the nose transitions to cartilage, where it starts to wiggle. That's the cartilage. Well, right around there, as I tell my patients, I like to draw the anatomy on the whiteboard, one of which I have in each one of my rooms. By the way, this has been a tremendous asset for me for teaching parents and medical and PA students, which I usually have with me, that I have this whiteboard, which really is very illustrative of a lot of things that we're trying to explain to folks. Do you have any of them, Bud?
I don't, but I want a picture of what you write on your whiteboard. It's like, is this like a stick figure of you with a guitar? What are you writing on those whiteboards?
You have to be there, actually,
I've seen your drawings. They're not that impressive.
So oftentimes when I'm making a list, like if I'm making a list of, okay, these are the potential meds used for like ADD or anxiety or whatever, and I say, hey, listen, go home and do your due diligence if you're leery about, our initiation of this, and take a picture of this and then get back to me and we'll talk about it.
I want
right?
some of those pictures.
Indeed you do. Who wouldn't? When a person can clearly see where the anatomy of interest is, there's a much greater success of having them treated at home or of having them explain how to treat it. So traditionally, we've suggested using Vaseline or some other type of oily substance, oily ointment, put into the nose, but we're not necessarily clear on how and why we do this. So this, drawing the picture is, kind of gives us the opportunity to make this more clear. And the timing is also important. You don't want to shove Vaseline up there right in the midst of any bleeding, because if it's starting to coagulate, you're going to knock the scab off. Right.
If it's really crusty up there, sometimes I'll use mupirocin.
There you go.
Instead of the
either
Vaseline.
one.
Yeah.
But the way I explain it to people is you put it at the opening of the nose, but then you kind of like gently work it up inside by moving it kind of further north into that area of Kesselbach's plexus.
Right.
And then we encourage them not to pick their nose or rub at it, both of which can be really tempting, even as an adult pediatrician, right, Rob? You thought I didn't see you, right?
Hey, it wasn't a pick.
Uh-huh.
It wasn't a
Digging
pick.
for gold
wasn't
there,
a pick,
Roberto.
Man. Not a pick.
Yeah, so this is the typical scenario for nosebleeds, but we do need to consider that a child may be more predisposed to nosebleeds, could be suffering from a bleeding disorder.
And I've said it before on this podcast, but I'm going to say it again. I love asking kids when they're having nosebleeds which finger they usually use to pick their nose. And they almost always, even the older teens, will just slowly raise their index finger. And then I love to say, the right answer is, I don't pick my nose at all.
Well, maybe you're an N value of 1, Rob.
It makes me smile.
Uh-huh. As we mentioned before, we treat most common anterior nosebleeds by having the child sit upright and pinching the area of the nose just below the bony part for 5 minutes. And I suggest setting a timer on the microwave. I mean, I can remember one of my daughters used to have these, and she'd pinch her nose for about 10 seconds and say, "It's still bleeding, Daddy." No, longer. So please don't shove any tissues up your nose. We'll talk about this in just a second, but on rare occasion, if the bleeding is unremitting, to place gently a Q-tip or a small cloth that has a little bit of Afrin or Dristan on it, because these are vasoconstrictors, that can be put to the site of the bleeding, but you kind of have to be brave to be able to do this. And only if you really trust the parent and the process should you recommend this. This is pretty much the only time to use Afrin in pediatrics.
The only time.
Yeah, I mean, I will occasionally tell folks to use it with great admonition and you can only do this for the next 2 days.
Right.
For kids who are horrifically congested, but you really need to stay away from that because, as you know, Rob, there is a rebound response to that, right?
Rhinitis medicamentosa.
I knew you wanted to say
stuffed
that. That's why that was a
time.
softball. I just tossed that to you so you could say that.
I know.
All right. But again, at some point, if it continues to be an issue, one does have to consider bleeding disorders.
Right. And you may send some to the ENT if it keeps happening. But you got to think about the bleeding disorders. And another common bleeding disorder presentation is very heavy menses known as menorrhagia, but also now known as abnormal uterine bleeding. Heavy menstrual bleeding generally means the use of 1 to 2 pads an hour or more than 6 pads per day, or menses lasting more than 7 days at a time. And when we evaluate these conditions, in addition to checking for abnormal hormone levels as a source or consequential anemia or iron deficiency, one must also consider bleeding disorders. And other ways bleeding disorders can come to light can be excessive bleeding after losing a tooth, so maybe a call from the dentist, excessive bleeding with minor wounds or with hemorrhoids, or with patient having much larger than typical bruising or bruising that persists much longer than typical with trauma to the muscle.
The key point here is that one must first consider the presentation may mean that a bleeding disorder needs to be in the differential as a source of the problem, and then one must ask about any family history of bleeding disorders. Many of these disorders are genetically driven and run in families. Usually a CBC, a platelet count, and a ferritin level are ordered to evaluate the overall status of the blood cells and platelets and to check the status of the patient's iron stores. Certainly, the provider should order a PT and PTT coagulation studies which screen for variants of hemophilia and other clotting disorders. A von Willebrand's panel to assess for the presence of von Willebrand's is an especially good idea since this is the most common inherited bleeding disorder. Getting the right von Willebrand screening can be tricky, so don't be shy about asking your friendly neighborhood pediatric hematologist for advice to make sure the lab panels are appropriate.
And Matt, I think we mentioned in prior podcasts, but both of us went to the med school in the 80s and mid to early 80s. And between 1982 and 85, over half of the hemophiliacs in the United States got AIDS from contaminated factor and clotting products. This tragedy continued until it was finally determined that many of the pooled clotting factors, which were routinely administered to hemophiliacs as treatment for their underlying bleeding disorder, were contaminated with the HIV virus. It was later determined that heating the factor infusions inactivated the virus, but a whole generation of children with hemophilia were decimated. And I can't imagine, I was kind of peripherally involved, like as a medical student, but those families and the pediatric hematologists, and I know a few of them then who were taking care of these kids, and they were, trying to help them, give them clotting products, and they ended up infecting them with AIDS, and most of them died. This certainly serves as a painful reminder that we need to be ever vigilant about what we don't know about the effect of emerging new infections, like we've experienced over and over again the last several years with COVID.
Mm-hmm. Yeah. One other pearl that Dr. Schultz provided was a caution to be watchful for Ehlers-Danlos syndrome if there are bleeding issues present in the patient. This is a connective tissue disease which occurs in a number of variants and can manifest with bleeding concerns. If Ehlers-Danlos or any other type of connective tissue disease is being considered, hypermobility can be a main finding in these patients on the physical exam. So a Beighton score, which I always have to refamiliarize myself with.
I say Beighton.
Yeah,
but I don't know.
Beighton. I used to say Brighton until I looked it up. Right. So yeah, which is a hypermobility assessment, is easily done and can be helpful in considering this type of diagnosis. The assessment gives points a number of atypical mobility findings. So if a hand is placed on a flat surface, palm down, and the pinky, or for that matter, other fingers can be raised up and hyperextended to more than 90 degrees. Yeah, up to 1 point for each hand. If a wrist can be hyperflexed to the extent that the patient can touch the hand's thumb to the forearm of that side, a point is assigned for each hand. If a knee,
as he says this, I'm doing all these and getting,
yes, you
I'm
are.
Getting 0 scores.
Well, that's good, Rob. If a knee or elbow can be hyperextended to more than 10 degrees, either or, then a point is added for each side that can achieve this. And a final point's obtained if the patient is able to palm the ground in front of them without bending their knees. So with this assessment, a maximum score would be 9. If there's a score of 5 or 6 or above, then the patient may have a hypermobility syndrome. What's your score, Robbo?
Well, I just did it, and my score is a 0. But in middle school and before that, I could put both my feet behind my head and rolled around. So that has to count for something. It was a little parlor trick I used to do.
I'm sure it counted for you being the laughing stock of your homeroom, as well as being condemned to the high school dating purgatory over the ensuing several years. But those high school cretins couldn't appreciate the physical genius of you, Rob. I can. Come on, let's see it.
I would even try, but I've had 2 back surgeries, so I'm not even going to try.
I can give our listeners a play-by-play while you launch into your acrobatics here. No?
No.
All
but
right.
So moving or rolling right along. If a patient demonstrates hypermobility, you should consider that hypermobility syndrome could be present. These can be benign. They usually are benign, but they also can have significant consequences such as vascular fragility, which can result in bleeding. So if there's a question, get experts like rheumatologists and geneticists involved.
Okay, so while you think about the creepy visual of little Bobby rolling around with his feet behind his head, we'll be back after this break. We are back. Lastly, Dr. Schultz discussed a topic near and dear to a pediatrician's heart, and that is anemia and the screening for iron deficiency anemia. We know that some of our patients may be prone to anemia due to some type of hemoglobinopathy that's detected on a routine newborn screening, also known as a hereditary metabolic disease screening. These screenings, done within the first few days of an infant's life, will detect a diagnosis such as sickle cell disease or sickle trait and some of the thalassemias. Hemoglobinopathy screens, which first started in New York State in 1975, are now routinely collected for all newborns in all 50 states. Delaware started this in 1985. My home state of New Jersey lagged behind. Rob wrote this. Did not make this routine until 1990. In Pennsylvania, not until 1992.
Pennsylvania was worse.
Yeah, I know. By 2006, all 50 states required this type of newborn screening.
So another pearl she gave dealt with counseling for sickle cell trait. Now, most of us pediatric caregivers were taught that if a child has sickle cell trait, not sickle cell disease, but the trait, and the child shouldn't experience any major health consequences, but there's a 1 in 4 risk that person could have a child with sickle cell disease if their partner also was sickle cell trait. So it's important to alert patients with sickle cell trait to this fact if they want to have a child. However, other than this, there's not much else we were taught about having sickle cell trait. And children and adults with sickle cell trait typically are not anemic. And we talked about this, I think, in a prior podcast, but the NCAA several years ago insisted that all of its athletes be screened for sickle cell trait. And knowing that if someone has sickle cell trait and they become very dehydrated with activity, they're more at risk for excessive breakdown of muscle during physical activity called rhabdomyolysis, which can have severe consequences. But there has been pushback recently that the point shouldn't be just screening for sickle cell trait, but the emphasis should be on that all athletes should be provided ample and free access to fluids and electrolytes during the activities in order to prevent dehydration, instead of looking to see if a child or an athlete has sickle cell trait. That includes not having workouts in the sun 2 to 3 times a day for several hours at a time with limited access to water, which is kind of the norm for a lot of these big college football programs. That's how you showed you were tough, is be out there all day in the sun and not drink anything. So a little bit of backlash to this mandated testing for sickle cell trait for all athletes, and just having common sense hydration rules would probably be enough. But that rule is still in place. And I don't know about you, but we get that. Like, oh, we need to get the sickle. I often do a hemoglobin solubility test.
Yep.
And that's quick, but they still have to go back and get this test.
They do. They have to schlep to a lab to get this test.
Right. And I'm not sure it makes much sense.
While we should emphasize that sickle trait is a carrier state and not a disease, there is evolving science that suggests that sickle cell trait can increase the risk of kidney medullary carcinoma. In addition, with age, there's a loss of the kidney's concentrating ability with sickle trait, so hydration becomes even more important. There's also an increased risk of hyphema, which is bleeding into the eye, into the cavity of the eye, with a trauma. Lastly, even if a woman with sickle cell trait conceives with a partner who does not have sickle gene, if that partner genetically carries C or D hemoglobin genes, then their offspring can get sickle C or sickle D disease, which is milder than sickle cell disease, but can still be a problem. So they should still get prenatal genetic counseling with their partner.
Right. It's not enough just to find out that your partner, if you have sickle cell trait, does not have sickle cell trait. Right. They still need to look into it more. So that brings us to the thalassemias. So we get screens for thalassemias, and if it comes back to our office a few days after the baby's born, that there's a small amount of something called hemoglobin Barts, 2 to 5%, it means that the newborn has alpha thalassemia trait, which is when it's missing 2 of the 4 alpha thalassemia genes. And for the whole life, they will always look like they're a bit anemic, and their blood cells will be small or microcytic. And the hemoglobin electrophoresis will be normal. That this alpha thalassemia trait is pretty common, and many in adults and children have this, but they're mistakenly called iron deficient, and they're put on iron over and over again. So it behooves us, if someone's anemic with small blood cells, to actually check the iron levels, check the stores with ferritin before they assume that they're iron deficient.
What's the old differential for microcytic anemia?
Okay. Lead poisoning.
Yep.
Thalassemia.
Yep.
Iron deficiency.
Yep. list. Sideroblastosis.
Thank you, Matthew. I did not know that.
I thought I'd get you on that.
You got me. So,
although I could have sworn you taught me that. So,
so if you're missing 3 of the genes, it's called hemoglobin H disease, which is more severe. There can be some hemolysis. I have a patient with that, and they're followed up at CHOP, and we know if they get sick, we need to check their blood count. If you're missing all 4, well, you're not going to survive because you need it. So that's the alpha thalassemias. The other common thalassemia is the beta thalassemias and the beta thalassemia trait. And this is not picked up at a newborn screen, so you need to get a hemoglobin electrophoresis to make that diagnosis. It's pretty common in certain populations, especially Mediterranean, Greek I always think of, North Africa, Middle East. Their baselines can be that they're a bit anemic, but have really small red blood cell sizes. So the MCV is very small. And if they have multiple genes out, there could be more severe types like Cooley's anemia when they miss more genes and require chronic blood transfusions.
Okay, so you only got 3 out of 4 out of the microcytic anemia thing, but do you remember what the Menser index is?
Oh, my God. So my chairman was Jazz Toi, James Stockman. If I didn't remember the Menser index, he would come up from North Carolina and wring my neck.
Yeah.
So you divide the MCV by the RBC count, like
Yep.
whatever in millions, and you get a number. And if it's under 13, it's usually a thalassemia. And if it's over 13, then it's likely maybe iron deficiency.
I remember which is high and which is low, since thalassemia usually the kids have really low MCVs, right?
Right. So the MCVs are much lower than usually iron deficiency. Right.
Gotcha. All right, Robbo. So how do you screen for iron deficiency?
So that's a great question. And I think it's something that I've thought about more in the last few years. And I think a lot of us do it differently, especially when we do the 1-year-old screen. We're supposed to get a blood count at 1 year of age. And I do that at the same time that we get the 1-year-old lead level, which is mandated by the state. I personally like to get a complete blood count, not just get a hemoglobin, which the AAP says, but get a full CBC, which means going to the lab, because it gives me the hemoglobin, but also an idea if there's possible iron deficiency by looking at the size of the cells, that MCV, which can be low with iron deficiency, and also possibility of thalassemia. Also the variability of the red blood cell sizes, which is called the RDW, which is the red cell distribution width, which is increased if there's iron deficiency. Also get a platelet count put in there, and that could be elevated with iron deficiency. So the simple hemoglobin by finger stick is easy, and a lot of pediatricians' office do in the office, but I don't like that as much. So what do you think? What do you guys do?
So this is actually a tricky, there's a tricky answer to this, because there are a couple different motives here. The first of which is decide whether the child is anemic. The second of which is to try to abide by the state's guidelines, that require lead testing.
Right.
And the third of which is a combination of what both insurance companies and the state require from us as pediatricians to provide evidence that we've accomplished, right? So for many years, up until the last couple of years, we would give a family a lab slip at the 1-year-old visit, and we asked for a CBC, just like you said, and a lead level. And probably 30 to 40% of the people actually got it done. And then at the 15-month visit, we'd give them another slip. And then at the 18-month visit, we'd give them another slip. And so what we found was not only were we not being able to discern whether the child had anemia, but then we were also being penalized, for not having what the insurance is considered to be a metric. So we did start to collect fingerstick hemoglobin and leads in our office. Now, we don't run them in our office. We then send them out to one of the bigger labs and get the result back. If then the hemoglobin is on the lower side, then we'll order a CBC. So that, I think, accomplishes close to what, the fullness of the evaluation that you accomplish. One of the other things that we'd often run into is that CBC that we get oftentimes will have values that are temporarily skewed. And so then we have to go back again and again with the family freaking out, like, why is their white count like 0.1 below what it's supposed to be,
right.
That type of thing. So it does create a bit of an unnecessary fuss, but also to your point, it can evaluate some things that would have otherwise escaped us.
Those are all valid points. I would say that our uptake is a lot better than 30 to 40%.
Right.
Not 100%, but better than 30 to 40%. So in that scenario, if the hemoglobin is normal, you don't get a CBC, correct? So here's this, hot off the presses, Maddie.
Oh, I know what you're going to say.
In 2022, December 2022, pediatrics, there was one observational study in December 22 pediatrics titled Chronic Iron Deficiency and Cognitive Function in Early Childhood. It suggests that chronic iron deficiency, we know, causes lower cognitive scores, and we've known that for a while, but that included lowering scores in kids who had a normal hemoglobin, 11 or above, but also showed signs of iron deficiency, and they got ferritin levels. And so these are kids that so far their hemoglobin's fine, but their iron stores are low. And we know one of the later signs of iron deficiency is actual anemia. a lot of things go on before you get anemic. And those are the kind of kids that I don't want to miss. So if I get a CBC and their hemoglobin's 11.1, but their MCV is a bit low, if their RDW is high, I'm at the very least saying, okay, we need to keep you on a multivitamin with iron. You need to push the eggs and the meat, not to crazy amounts, but we need iron-rich food, cereals that are fortified with iron. So I'm interested in seeing what happens. I could do a Menser index on a CBC, but not a hemoglobin. So this is new data, and we'll see what happens. But if we just get a hemoglobin and it's 11 and we say it's okay, or it's 11.5, we may be missing kids who have iron store deficiency, which could cause cognitive issues.
You bet. And I envision a future where, basic CBC, the capacity to do a full CBC within the office becomes a lot more affordable, right? I mean, for us, just having some of the equipment we have in the office is a break-even type. It's a zero-sum game, right? I mean, whatever the expenses for our office to have it, we're not actually realizing any benefit from it aside from the fact that it's convenient.
Right. And there's also the office flow issue. Even though we got a lead machine, it was hard to keep our office flow, and we're all struggling with staffing.
You bet.
So you need an extra person, so it just made it difficult. Now, we're so lucky, and both of us are, like we have a children's only lab nearby that a lot of places in the country don't have.
Right.
And a lot of our families can travel and they have the wherewithal. So I've got there's something, but I think at the end of the day, what we end up with is that we'll need something better than a hemoglobin, in my opinion, if we can get it.
Oh, I agree. It's certainly second choice for me, but I think our patient population might be slightly different than yours. Not a ton different, but different enough that it was to our advantage not to have our staff spending a lot of their time calling people and encouraging them to get the tests that they hadn't gotten yet, as opposed to just, this is a no-brainer. You're going to get your immunizations at a year, and we're going to prick your child's finger.
Right. I know.
Again, it's not fail-safe, but for us at least, that's so. There are a lot of ways to do this, folks.
Right, absolutely, Maddie. But okay, if they do have iron deficiency anemia, Maddie, what do you do?
Yeah, so I mean, iron deficiency is common in kids. It causes anemia, it causes fatigue and restless leg syndrome, and most significantly, as Rob just alluded to, some developmental delay is possible, and diminished attention. And so, foodstuffs like meat and eggs and poultry and seafood are all good sources of iron. Infant formulas are fortified with iron, as are infant and children's cereals. If a baby's breastfeeding, there's a higher risk of not getting enough iron if the baby's mom is iron deficient, so many parents will start vitamins with iron at about 4 months of age, or until they're taking solids that are rich in iron.
And I also start a vitamin with iron on every patient who's vegetarian, with that exception. Like, you're vegetarian, just take a multivitamin with iron.
There you go. And of course, there are ways to get adequate iron as a vegetarian, but at least as it's understood here in most of the cultures in the U.S., folks don't tend to realize that they have to be consuming certain foodstuffs to be able to get that. So another pearl for when we check for iron deficiency is, as Rob has alluded to be aware that a normal ferritin level, and ferritin is indicative of iron storage, does not always guarantee normal iron stores, since ferritin can be an acute phase reactant. And so if it's elevated when there's something significant going on in the body, that can be confusing. So if a person is sick or has some type of an inflammatory process going on, the ferritin level may be elevated kind of falsely, not the baseline.
Right.
This could create a normal appearing ferritin level in a person who does not actually have good iron stores. But on the other hand, if the ferritin value is low, which is less than 15, then the patient definitely has decreased iron stores. And the 15 is what we generally use, although every lab seems to have its own,
and if
norms,
If they're 17, I still think they're probably may need some more iron.
Yeah, getting an iron level gives you an idea of what the iron levels in the blood are. I generally get the ferritin. I'm not so keen on the iron level. I know you like to get the iron level as well when I check for iron deficiency.
As we said, in general, we want the hemoglobin to be at least 11 from 6 months to 5 years old, and 11.5 from 5 to 12 years old, and at least 12 for those over 12 years old. So, again, what if the child is iron deficient? How do we treat it? Aside from the iron-containing foods, we suggest iron supplementation, and usually in the range of 3 to 6 milligrams of elemental iron per kilogram for per day for several weeks. But another pearl that Dr. Schultz gave us is that we can probably just do the lower 3 per kilo and give it every other day. And that's a big deal because if we give it every other day, we're really going to get a lot less GI issues, the classic constipation, the stomach upset, the things that parents say, I don't want to do iron because that could be a problem. And I've been doing it every other day since she said that and had good results. My own pearl, a little bit from bad experience maybe, is that you need to warn parents if they're getting supplemental iron, not vitamin with iron, but truly iron therapy, that it could temporarily stain their child's teeth. So they want to put the iron drops in behind the teeth and immediately after brush their teeth, have them drink something so they won't get stained with iron. Also, warn them about kids putting their fingers in their mouth because then their fingers get stained with iron right after they put the iron in. And parents are not particularly happy when their child has staining on their teeth or their fingers from the iron therapy.
Yeah, we actually experienced this at my house. My oldest needed open heart surgery when she was 2, and so her cardiologist has suggested giving her some elemental iron just to make sure that we got her levels, her blood count up as high as we could.
Right.
And it did indeed stain her teeth for a little bit. Yeah, we weren't wise enough to put it behind our teeth.
Well, neither was I for years. So now I am.
For the young children who need a liquid medication, I like using an iron supplement called Ferrinsol, which is 15 milligrams of elemental iron per ml. So remember, an ml is less than a quarter of a teaspoon. So that's a good bump for a small volume. Also like the Fiasol pills for older kids. These have 65 milligrams of elemental iron per pill. These meds should be taken with water or juice, but never with milk or any other calcium-containing liquid, since this can really compromise the absorption of the iron. We'll usually treat the kids for 4 to 6 weeks and sometimes a bit longer for severe anemia. You can repeat a blood count and perhaps a reticulocyte count with a significant anemia, and then I always like to do a ferritin as well. I'm sure Rob does it also.
Right.
Once there's been adequate opportunity for the iron to decrease the anemia or the iron deficiency. Once adequate levels are reached, continue to encourage the family to focus on getting enough iron, which for some may mean routinely giving a vitamin with iron. And I think that's a wrap, Rob. I think that's about it for now.
Well, yes, we have got to go. Got to get ready for my daughter's wedding. We're in the broadcast room that has all the clothes that I have on the bed for the wedding in June. I have to work on my Fathers and the Bride toast. So when we get off this podcast, I got to pick your brain because you gave a great Father.
Thanks, man. It was one of my finer moments.
It was so good. And please, Matt, I've been asked to ask you, don't wear your Crocs, especially your red Crocs, to the wedding.
Come on, man. They're all shined up and ready to go. Well, it was bad enough, I think, that I invited myself to the wedding, right? By the way, for those of you who want to attend a wedding, just RSVP without having gotten an invitation. It confuses everyone.
But the one thing about it, though, is back when Matt was a resident, I think, he was my resident back in the day, 30 years ago, his lovely wife, Diana, was my Abby's nanny.
Yeah, that's the only way I got an invite to this
for
soiree.
a year. I don't think she remembers it as much, but that was a really cool connection.
She remembers it.
Okay.
Yep.
So, well, Diana does. I'm not sure Abby at one remembers too much, but she's bright. But all right, say goodnight, Maddie.
Good night, Moon.
Baruch Hashem.
Nice.
Podcast Pediatricians Productions. All rights reserved.